Okay, everybody. We're going to begin the afternoon session here. And we're going to start with, I think, in many ways, what's really, in many ways, a highlight of this entire summit here. This afternoon, we're going to have two outstanding physicians who are going to have a little discussion, fireside chat, and then we're going to take some Q&A from the audience on this. So let me begin by talking about who that's going to be. First, we're going to have Dr. J. Butler, who was appointed by Governor Walker. Yeah, he's great. So again, I was going to kind of go into the full bio, but it's so long and impressive. He's essentially Alaska's Surgeon General. All right, that's what he is. So a great, passionate advocate on these topics, and he is going to be interviewing the United States Surgeon General. This is Vice Admiral Vivek Murthy, who was confirmed as America's 19th U.S. Surgeon General in 2014, also known as America's Doctor. Now, a lot of you know that our Surgeon General, who has not been to Alaska, he's been traveling all over, though, which is great. So this is his first visit. He literally has been the leader in the country. Turn on CNN, turn on any news show about trying to explain this epidemic, trying to educate, trying to give advice to communities throughout the country. And that's what he's going to do this afternoon in a few minutes. Let me also mention that he's in charge and oversees the U.S. Public Health Service Commission Corps. That's 6,700 uniformed health officers who serve to promote, protect, and advance the health and safety of our nation. Now, if you're wondering, can you guys stand up? So we have some of the officers right here. And as a Marine Corps officer, I look at that and go, that is a sharp uniform. So I really want to, I'm excited about this next panel, and I'd like everybody to give a warm welcome to the Surgeon General of Alaska and the Surgeon General of the United States for a fireside chat for the next 45 minutes.
Welcome, everyone, and welcome back from lunch to our fireside chat with Surgeon General Vivek Murthy. Where's our fire? That's the first question. I don't know. Where's the fire is usually a question I get from the troopers, but that's another
My
story.
guess is somebody in this room could build one right here.
Okay. I think we definitely have the energy to do that here. So, Surgeon General, how should we address you? Is it doctor? Is it general? As I recall the significance of that stripy action on your sleeve, is it Vice Admiral?
Well, good question, and people ask me this all the time. I was telling some folks the other day that everyone has heard the title Surgeon General, but very few people actually know what the Surgeon General does, why the Surgeon General wears a uniform. The other day I was getting on a plane, and the woman in front of me said, she looked back and she saw me, she said, "Sir, why don't you go ahead in front of me?" And I said, "No, I'm happy to wait my turn in line." And she said, "No, without you, we can't fly the plane." So there's a lot of confusion. So I appreciate the opportunity to set the record straight. I do not know how to fly a plane, but the reason The reason I wear this uniform is because the Surgeon General is part of and the head of the United States Public Health Service Commission Corps. And you had the honor and the opportunity to meet some of our officers who are right here in the audience. And we, in fact, have many officers who are all over the country. I met a number of them yesterday in Anchorage, but also met more officers in Bethel and in Napaskiak, where I was yesterday. We are just so proud that they are here and that they are serving and advancing the public health of the state. But the role of the Surgeon General is really twofold. It's to, one, communicate the best possible information on health to the public so people can make good decisions about their health. But the second is to work with and to oversee the Commission Corps of the U.S. Public Health Service. And people call me different things. You know, most people call me Dr. Murthy. Some people call me Vice Admiral Murthy. That is my rank title in the Public Health Service. And other people just call me Vivek, which you're welcome to do as well.
Well, for our discussion today, I'll go with Dr. Murthy to show the respect to not only the office, but your training that you bring to the discussion today. So over the years, of course, the Office of the Surgeon General has represented a number of different responses to a number of different health priorities across our nation. So I was wondering if we could start with asking you to share some of the priorities that you see in healthcare and in public health today.
Well, you're absolutely right that our office has a long legacy of working on critical public health issues. Many people remember the anti-tobacco efforts that have been the hallmark of the Surgeon General's office, and that began with Surgeon General Luther Terry back in 1964, who issued the first ever Surgeon General's report on tobacco, and that kicked off a half-century's work on tobacco, which have helped to reduce our smoking rates from where they were in 1964, which was at 42%. To below 17% today. So we still have a lot of work, but there's a lot of progress that's been made. When I entered office, I was thinking about a number of things. I was thinking about what I understood as a public health expert to be the challenges that our country faces, but I was in particular thinking about the patients I had cared for over the years, the thousands of patients who I had been privileged to play a part in their life, and was trying to understand what it was that they were facing and how the health challenges that they face were so intertwined with other challenges, with economics, with culture, and with other issues. And so for me, there are two big themes that guide me in the office, two big issues, if you were. One was the need to shift our country more toward a culture of prevention, because we are a country that invests a great deal on the treatment side, in developing new medicines and therapies, in building hospitals, and those are important. And it's for that reason that we have some of the best therapies and medical care in the world. Even though I should say, that doesn't mean that everyone in our country has equal access to that. We know that's a problem, and it's especially a challenge here in Alaska. But we don't invest nearly enough on the prevention side. Now, if I were to ask anybody in the audience, would you rather get diabetes and then treat it or prevent diabetes in the first place? That would be a no-brainer question, right? You'd say, well, I'd rather not get diabetes at all. But that is not at all how we invest as a country. So that's something that we have to change. But what does that mean, though, to actually shift toward prevention? Well, the reason that it's actually challenging is because it's not just something that doctors need to do. It's something that all of us play a role in. When you really start to dig into the origins of illness, you start to see that the structure of our communities, whether they're walkable or not, can have an impact on health. You start to see that whether or not neighborhoods are safe has an impact on health. You start to recognize that the food that children are exposed to in schools can have an impact on health that goes well beyond their time in school. And you can also start to see that the workplace, a place where people spend a significant portion of their lives, can be a place that can lead people toward better health practices and give them opportunities to both be more physically active, but also to eat healthier foods. And so all of us have a role to play when it comes to creating this culture of prevention. But to me, that is one of the most important things that I want to accomplish as Surgeon General. The other value is around health equity. And that's to me, it's a value and not just an issue. It's a value because health equity means that we believe as a country that everyone should have a fair shot at a healthy life. That means that if you're a young child who happens to be born into a neighborhood which might be poor or might be in a rural part of our country. And just because of that, if that means you don't have access to good health care, and if that means that you can't get access to opportunities later in life, to me that's not only not fair, but that's not really in the spirit of our country. You know, our country is based on the idea that everyone has the potential to contribute. Everyone has the potential to add value to their community and to the people around them. And that means that we have to do everything we can to ensure that health equity or equal opportunity when it comes to health is something that everyone in our country can experience. So for us, and for me, those are two values that guide me in everything we do. In 2016 in particular, though, we have made opioids one of our key priorities, and we're thinking about it both on the prevention side and on the treatment side. It's also one, and I'll talk about some of the work that we're doing on the opioids front. But in addition to focusing on opioids, we are also later this year going to be rolling out a campaign on e-cigarettes as well, which is a question and a concern that comes up everywhere I go, because I was actually in Seattle about a year ago, and had a teacher raise her hand in a session I was in, and she said, "Dr. Murthy, I've got rules in my classroom which say that kids can't chew gum, which say that they can't certainly bring alcohol and drink, that's not allowed. They can't draw on the desks and the tables. But you know what? They're smoking e-cigarettes in the classroom." And I said, "Well, how is that?" And she said, "Well, we don't have a rule on it because the city doesn't have a rule on it, and they don't have a rule on it because they're not sure what to do about e-cigarettes." So that's one of the reasons why we are rolling out a campaign on this, to help people understand what the science really tells us about e-cigarettes.
Well, you mentioned tobacco, and that's a great example of where culture changes and we move towards a culture of health. If we were having this discussion 60 years ago, I'm sure there would be an ashtray between us, and if I were Edward R. Murrow, I'm sure I would be smoking away. That doesn't happen nowadays. If I asked you, would you mind if I smoked, you would look at me very funny, besides the fact that I'm in the job that I'm in. But part of what started all that was Dr. Terry's report in 1964, the Surgeon General's report, the first report on tobacco and health. You've recently announced that you're planning a Surgeon General's report on addiction and health. I was wondering if you could tell us a little about that, and where would you like to see us go with that as a nation?
Well, you're absolutely right that culture is such an important part of changing outcomes when it comes to health. When I was building, before I was Surgeon General, I had sort of a few different lives, and one of them was actually building a technology company that was intended to enhance the efficiency of clinical trials to help us get effective medicines to patients earlier. And I remember when we were building our company, and I was getting some advice from another business leader, he once said to me, he said, "Make sure you take particular care about the kind of organization you're building inside." Because he said, you gotta have good policies, but he said, culture eats policy for lunch every day. And what he meant by that is that you can have really good rules and regulations, but it's the more informal norms and beliefs that ultimately guide much of what people do. And this is very relevant when it comes to addiction. If somebody had told me when I entered medicine that I would be seeing that a large portion of the patients that I cared for would have substance use disorders in the background or either as a primary issue, I would have been shocked. I thought that, when I came into medicine, that the majority of patients I would see would have pneumonia, would have infections, would have trouble with their heart, would have diabetes that was perhaps out of control and needed help. But in fact, what I realized is that so many of the people that were coming in to see us actually had substance use disorders. And part of what we have to do here is not just make sure that, there's several things we have to do. And I think this is particularly poignant when it comes to the opioid epidemic. As all of you know, opioids are essentially, or prescription opioids are prescription painkillers that are very powerful, and they can be quite addictive. The challenge is that not everybody knows they can be addictive. And so we have this situation that we got into, which is very unfortunate. But it was paved on we got here really on a path that was paved with really good intentions. But what happened is about 20-ish years ago, clinicians, doctors, and nurses were urged to treat pain more aggressively. But they were urged to do so without necessarily being given a lot of training or support in how to do that safely and effectively. And that also coincided with the heavy marketing of opioid medications like oxycodone to doctors by pharmaceutical companies. It was also accompanied by just a lack of knowledge about how addictive these drugs were. And what we saw is that from 1999 onward, there was a quadrupling in the number of opioid overdose deaths. That coincided with a quadrupling in the number of prescriptions that were written for opioids. And so we've now come to a situation where we have nearly 2 million people who are addicted to prescription opioids. And the prescription opioid epidemic is leading more people to heroin. It's also contributing to the spread of HIV and Hep C. And that's why one of the things that we are doing is actually building a campaign called the Turn the Tide campaign, where we are traveling around the country to engage in particular with clinicians, with doctors, nurses, dentists, and nurse practitioners, to ask them to join the national movement we are building to change and sharpen our prescribing practices, to get naloxone in the hands of first responders, to expand access to treatment, which we know is essential for people living with substance use disorders, and to also help educate the public about the fact that opioids are addictive. But perhaps the biggest thing that we have to do is the most challenging, which is that we have to change how our country sees addiction. And this is a cultural challenge. Because right now there are too many people who see addiction as a bad choice, as a character flaw, but they don't see it for what it is, which is a chronic disease of the brain, and one that we have to treat with the same urgency and skill and compassion that we would treat diabetes or heart disease. Later this year, as Dr. Butler mentioned, I'll be releasing the first ever Surgeon General's report on substance use and addiction. And the reason that I'm doing that is because number one, we want to bring together the best available science on prevention, treatment, and recovery so that we can get that in the hands of people who are taking care of patients. But we also want policymakers to know where the evidence stands and what it tells us about what programs work so that they can help support and expand those programs. But I really personally want this report to not be a sheaf of papers that sit on a shelf and is intelligible to only people who have an IQ greater than 200. I want this to be a report for all Americans, the kind of report that all of us can look at if we're worried about our son or our daughter, or our mother or our father, or our brother or sister, and a place where we can go and find out more about what this illness might be and how we can actually get help. So that's the purpose for me of doing this report. It's more than a set of papers. To me, it's the beginnings of a larger movement that we have to build to take on addiction in America.
Yesterday at Grand Rounds at Providence, you mentioned that you'll be sending a letter to all the providers around the country. And we certainly heard from providers expressing some of the frustration that you've touched on today in terms of not being sure quite how to manage their chronic pain patients, not having a background in how to manage addictions. Tell us a little more about what you hope to achieve with that letter. I'll say as a physician, we get a lot of letters, we get a lot of mail. My wife's out here, she knows what shows up in the mailbox every day. So tell us a little bit more about that.
Sure, I'm happy to. Well, it turns out that in the entire history of the Surgeon General's office, that the Surgeon General has never sent a dedicated letter to healthcare practitioners calling them to action around a topic. And that is actually one of the reasons we want to do it, because we believe that this is one of those moments where it is so important to call our profession to action. And to us, it's more than about a letter. The letter is a jumping off point. But with the letter, we're also including a pocket card that clinicians can use to help guide them in how to treat patients who have pain, a card that they can keep in their white coats or that they can keep in their fleeces or in their suit pockets. We're also accompanying that with a series of visits around the country, and that has been the purpose of our Turn the Tide tour. It's the tour that has taken me to Tennessee, to Oklahoma, to Arizona, to New Mexico, to Maryland, to Massachusetts, to Alaska. We'll be going to, we actually went to Ohio as well. We'll be in Illinois later on, in New Jersey on Monday. We're going all over the country with the intent of making sure that our message doesn't just rely on one piece of paper, but that it reaches people in different ways. But the real message behind the letter to our fellow clinicians is that the movement that we have to build in our country to take on the opioid crisis is one that physicians and nurses have to step up and help lead. Because for many of us, we were trained to stay in our offices and to care for the patient who is in front of us. And that is, let me tell you, more than a full-time job. It's challenging. It takes a lot of time and emotional energy as well. It takes a lot of time spent trying to keep up to date with the science. It's hard work. But we know now that unless we have clinicians stepping up to not only shift what they're doing in their practice, but also be a voice in their communities to help change how people see addiction, unless we do those things, I don't think that we're going to be able to get past this crisis. And that's why, to me, it's incredibly important that we mobilize members of our profession. But I'll tell you one last thing about this, though, which I find interesting, which is that when I talk to clinicians around the country, there are many who feel like they're burning out. And I'm curious, just by a show of hands, how many of you either are a clinician who is burning out or feel like you know or have heard about clinicians who are burning out? Okay, so huge number of people in the audience. This is a really common problem in America. The suicide rate among doctors is unbelievably high. And when I ask myself why that's the case, there are multiple reasons. Some of it has to do with a lack of self-care that's really taught in medicine. But some of it has to do with a lack of self-efficacy that many clinicians feel in their practice. And when it comes to addiction, this is actually a real challenge. I'll give you a simple example. If I have somebody who is coming to me once a week for pain and for refills of their pain medications, and if I feel that these medications might be doing them more harm than good, but I don't know how else to treat their pain, I don't know how to connect them to help, and I feel like I just don't have the resources to give them ultimately what they need, that's not going to make me feel good as a clinician. And if that happens day after day with so many patients, that leads clinicians to feel frustrated and a sense of futility. So part of our hope in this movement that we're building is to give clinicians the skills and the perspectives that they need to be able to better serve their patients, which is something that every clinician wants to do. No clinician got into medicine because they just wanted to write prescriptions. And while physicians make a decent living, most clinicians didn't go into medicine because they wanted to be extremely rich. Most of them went in because they wanted to help people. And that's what we ultimately want to do in our campaign, is to better enable clinicians to help the patients in front of them who are living with substance use disorders and who need help.
One of the issues that came up this morning is the question about prevention. We spent a good bit of time talking about the neurobiology of addiction and how that relates to treatment. I wonder if you could tell us your thoughts on how do we prevent addictions?
Well, it's a good question, and I'm glad that there was a talk earlier today about the neurobiology of addiction, because this is not something that's just in someone's head. Substance use disorders affect us on a deeper level, on a physical level. They are diseases of the brain. And it's important that we understand the science behind that. But what the science also tells us is that when you begin using substances of abuse, whether they are opioids or alcohol, at a young age, your likelihood of developing addiction is far greater than if you start using those substances later. So when we think about prevention, one of the things that we have to do is focus particularly on our youth and to make sure that they have the knowledge, the support, and the guidance they need to be able to stay safe and to not start experimenting with some of these substances which we know can be harmful. The second thing we have to do on the prevention side is look at our prescribing practices. I mentioned earlier that since 1999, we've had a quadrupling of opioid overdose deaths. But we've also, at that same time, in parallel, seen a quadrupling in the quantity of opioids that are prescribed. And that's very concerning to me. While very few physicians out there are writing pain medication prescriptions because they're trying to make money, they're doing it because they want to treat suffering. While that's the case, we know that some of these prescriptions that are being written may not be necessary. We know in some cases they can begin helping somebody but quickly turn to a place where they're creating more harm than benefit. And that's also something that we have to change. We have to figure out how to work with clinicians to sharpen these prescribing practices. Now, that's not a simple thing to do. It requires changing how we educate doctors and nurses and dentists. It requires having tools like prescription drug monitoring programs, which can help clinicians understand whether their patients are already filling prescriptions for pain medications at other places, which will then in turn make them more cautious about giving them new prescriptions. These are some of the tools that we have to have in place to support our clinicians. But that is going to be an essential piece of prevention. And the last part of prevention has to do with all of us, which is that when we create an environment where people can come forward and ask for help, when we create an environment where we can talk about substance use disorders openly, we make it easier to educate people about these disorders and about how they can actually prevent them. Right now, in too many communities, addiction is a taboo. It's not something you talk about. You know, so many people have told me they read obituaries sometimes in the papers of young people who have died, and they see euphemisms and nuance in those obituaries that lead them to wonder, did this person have, was this somebody who was living with addiction and was that their cause of death? And a lot of times they don't know because families are ashamed to admit that. But more and more, actually, we're starting to see families speak out and say, you know, I loved my son dearly, and he meant everything to us, and we were heartbroken to lose him, but he died from opioid addiction, and we want every family out there to know this was the case so that they can protect their own children. We're seeing more people step up and do the same. And yesterday when I was at Providence, Alaska Medical Center, you know, I had the privilege of being with Karen Nelson, who is a wonderful advocate and champion, who is somebody who is living in recovery right now, who has come through the long, dark tunnel of addiction and is on the other side of that and is helping other people through that journey. But I told Karen, and I'll tell you the same thing I told her, which is that to me, the most inspiring part of this work is meeting people who have gone through incredible pain due to addiction, but who have turned that pain into a passion for helping other people. And that is the bright side of this crisis. And as I told Senator Murkowski and Senator Sullivan and others earlier this afternoon, what has impressed me so much during my trip to Alaska, whether it was the time I was in the village in Napaskiak or in the big city here in Anchorage, was this strength and the resilience of the Alaskan people, a strength which is greater than the magnitude of the crisis that we face. But we lose when we forget that. We lose when we forget about the role that each of us has to play in overcoming this epidemic, whether it's by changing how we prescribe or helping change how people around us think about addiction.
There's been no shortage of hard questions and even criticisms of what everyone in this room is trying to do to address the opioid epidemic. One that sometimes is raised is, well, why now? And I'm sure when you did your training, I'm a little older than you. I'm from the days when we saw mastodon maulings in the ER, but I took care of heroin users. And I did my training in Nashville and in Atlanta. But they were primarily poor, inner city, predominantly African-American people. We've seen opioids spread across the land, as has been said. Certainly, Appalachia was another place, and you know, when it started there, it was sort of a subject of jokes. People talked about hillbilly heroin when they were talking about oxymorphone. The criticism has actually been raised earlier today also of, well, it seems like nobody responded until the epidemic spread to the suburbs, that inner city and rural areas really didn't matter as much. People of color did not matter as much. How do you respond to that criticism? I didn't say that all the questions would be easy. So.
No, I'm glad you asked this. And I told Dr. Butler this earlier, but when we open it up to Q&A, I don't want people to hold back. You should ask the questions that are on your mind. I think that there's a lot of legitimacy in that criticism. You know, I think the truth is that 20 years ago, when we were dealing with epidemics involving heroin and crack, there were a lot of people who saw those through a racial lens or through a class lens and saw, oh, well, you know, it's just poor people who are, who get into trouble with addiction, or it's just people or communities of color that get into trouble with that. And you know, that wasn't, we know that wasn't right. And what we've seen is this epidemic spread to many other communities as well. And the truth is, it was affecting a diverse community to begin with. Just we didn't really recognize that. That's not how it was portrayed as an epidemic. But we have a chance to correct that now. We have a chance to recognize that addiction doesn't discriminate based on your skin color or how much money you make, or whether you live in a rural or urban area. We know that it's a disease of the brain that can affect everyone. And if we had taken that approach 20 or 30 years ago, I dare say we would have been in a better place than we are now. But we have a chance now to make sure we're not in a worse place in the next 10 or 20 years. And that becomes our responsibility right now. And to me, this is an important piece that's related to the value of health equity that I mentioned earlier, which is to recognize that everyone deserves a fair shot at a good life. Everyone deserves a fair shot at good health. And part of that means making sure that we're recognizing that all of us are susceptible to a challenge like addiction, and making sure that we get help to everyone who's living with addiction regardless of where they're from. You know, I'll just tell you, I was in Arizona just a few months ago, and I met a young man there who was probably in his early 30s, and he told me that he got into using prescription opioids when he was in high school. He said he never felt like he quite fit in, and it was only when he took opioid medications that he kind of felt good about himself. And that developed into a longer addiction. Now, as time went on, you know, he had other health challenges. He was diagnosed with testicular cancer. He was treated. He was in remission for a while, but then he was told one day that he had recurrent testicular cancer. And if I told any of you here that you had a recurrence of cancer, would you be happy or sad? I'm sure that almost everyone here would be sad. He was elated. And the reason he was so happy is he figured that he would need another major surgery and would be able to get more prescriptions for opioids. Now, he shared that story with me to illustrate just how powerful addiction can be in changing your reasoning and judgment. It can really literally take control of your brain at times. And that's not something it does based on whether you're black or brown or native or white. That's not something it does whether you are rich or poor. That's something it does because you're a human being. And that's why we know that addiction can affect all human beings. We're seeing that now. And you know why we're seeing it in part? Is also because more and more people are coming out of the shadows and talking about it, which is a movement that we have to support and we got to continue to build. And that's why each time somebody does come up and step up and talk about it, you know, we all have to encourage them because they are doing something that is brave. It's a lot easier, honestly, to step up and run a stage and say that you have diabetes. You know, even though diabetes has a lot of challenges, it's not fraught with the same type of negative perceptions and prejudice that addiction is fraught with. So that's part of what we have to change. So absolutely, yes, there have been, I think, problems with how we dealt with addiction in the past. We began a war on drugs that became a war on the people who use drugs. Yeah. And that was a real problem. But we have a chance to correct that.
Well, I think we have time for some questions from the audience, if you're willing. So I think there's microphones out there. Why don't we start front row center? I don't think you even need a microphone.
Last time I saw you was at the presentation, and when you made the historical announcement. But what I wanted to ask you here is, Alaska is very unique because of our isolation. We're not like the lower 48. That's what we call the other states, the lower 48, where you can go to the next state. If you have an addict, I run a nonprofit, and my daughter is an addict. And every time she's come to me for help, if I don't get her that day help, I lose her the next day. Or the next addict that comes to me that wants help, if I can't find it immediately, I lose them. Is there going to be a unique approach to how we're going to get help up here because of our uniqueness?
Well, thank you for asking that question, and thank you for the work you do in your nonprofit. I really appreciate that. Thank you. So the question that was asked was really good, and I'm glad you asked that because this is a question that came up yesterday when I was actually visiting Bethel and Napaskiak as well. And the truth is that there are unique needs that Alaska has. There are many Alaskans who live in areas that are not so easy to access by car. In fact, when we went to Napaskiak, we had to take a boat to get there. There are also many residents who may not have as easy access to technology and the internet as others do. But I think part of what we have to do when it comes to making sure everyone has access to treatment is that we actually do need to think about how to use technology more creatively and more broadly to bring access to behavioral health services in particular that people may not have access to. When I went to Napaskiak, for example, in the midst of everything that was going on there, they took me to a small building that was their clinic. And there in one corner of the clinic, they had a video teleconference system set up, which was able to provide behavioral health services to residents of the village. And that was very powerful. Now, that's not to say that video teleconference is the answer to everything. It's not. It's one of several tools, though, that can help us. And that's part of the treatment methodology that I think we need to invest more in. Because what they were telling me is that there are now residents of the village who are able to utilize services from providers in Anchorage and from other states in the lower 48 as well. And so that's something that we need to invest in. And in fact, just not too long ago, the United States Department of Agriculture has made $2.2 million in grants available to Alaska, in particular to expand telemedicine options. It's also why earlier this year, the Health Resources and Services Administration, which is part of the U.S. Department of Health and Human Services, put aside $94 million in grants to expand treatment, and $1.7 million of those grants actually are coming to Alaska. So we got to do more of that, though, because we know that providing treatment is not simple and it's not cheap, because many people think that treatment for addiction is just giving someone a pill, giving them some methadone or giving them some buprenorphine, and it's not that simple. But when we talk about evidence-based treatment, which is medication-assisted treatment, we're talking about both the medicine, but accompanied by behavioral health services and social services. We need to have that full set of services available. We know that's expensive, and we know it's not simple. But lastly, I'll say that in addition to using technology more in Alaska, we know that there are going to have to be solutions that are driven by Alaskans, by people who know the state well, who understand the needs of the community. For example, I know the community health worker model, which has been used very effectively in many other countries to get care to remote regions, is one that is being used in parts of Alaska with great benefit. That's the kind of model I think we should be investing more in and expanding, so that we can empower people to be able to bring care to where people are, whether it's through a person, a community health worker, or through technology. So President Obama, lastly, I'll say I'll just tell you that he really understands how important this problem is around opioids. He has made the opioid epidemic one of his top priorities to address during his term. And most recently, he has requested an additional $1.1 billion from Congress to help fund efforts to address opioids throughout the country. But a large portion of that $1.1 billion is going toward investing treatment. And my hope is that if Congress allows that money to come forward, that we can use some of that to expand sort of remote services, either through community health worker models or through video teleconferencing technology and telemedicine, because that is ultimately the kind of help that I believe remote areas in Alaska in particular could benefit from.
Dr. Murthy, if I could just add also as part of the response to that, while Alaska has some unique challenges, we also have some very unique opportunities, and one in particular is the strength of our tribal health system. I think that is something that we've seen a little of that discussed today, but that's a particular strength that we have, particularly in our rural areas as well as our urban areas. I hate to go right up front. How about right there in the red shirt? If anybody could get a microphone.
Right here.
I'm just making it hard for the people with the microphones.
So my name is Justin. I'm a fourth-year pharmacy student, actually in Idaho, and I'm doing a rotation up here. I know as a pharmacy student in pharmacy school, we have programs called APHA, ASP, where we go out to communities and we do things like Generation RX, where we're educating young kids on prescription abuse. Does the AMA have a thing for when they're educating their prescribers, the practitioners, providers, of something similar to that, where maybe it can, for the preventative model?
So it's a good question. Justin, first let me just thank you for going into pharmacy. We need more good pharmacists in the country, so thank you for making that commitment. And I'll also tell you that pharmacists have a really important role to play here, because while pharmacists may not prescribe the medicines that patients fill, they are, and you know this, but I want everyone else to know this, pharmacists are an important point of contact for patients when they're filling their prescriptions and when they have questions about them. And so they play a really powerful role in educating the community about issues like opioids. You're absolutely right that the preventive education is really helpful, and I'm glad that you're getting some exposure to this in the middle of your training, because we have to start early when medical students and nurses and dentists are just starting their careers. The AMA and other medical organizations have certainly urged doctors, and in particular with the AMA, to take a closer look at their prescribing practices to recognize the connection between their prescribing and the opioid epidemic. And that's helpful, that they have taken a stand on it, that they've put information forward. But we know that in addition to having that kind of information available, we got to make it real for practitioners, right? Because as Dr. Butler was saying, people get inundated with a lot of stuff, right? Whether that's letters in the mail, emails in your inbox, people now, sending you sponsored tweets on Twitter. There's a lot of stuff coming at you. But what makes the biggest difference often, and this is something we're all taught in our medical training, right, is experiences you have with the patient at the bedside. And that's why, to me, what's really important is to make sure we're working with medical schools and with residency programs, with nursing schools and pharmacy schools, to roll this into the practical training so that you're not just getting it in the first couple of years of school when you're sitting in a classroom, but you're also getting it when you're working in a pharmacy, when you're out on the wards as a third or fourth year medical student caring for patients, and you're understanding how to make those difficult decisions about whether to give somebody opioids or not, about what to do when you recognize somebody may have a substance use disorder, and how do you actually connect them to treatment. So that's something, this is a larger set of cultural changes I think we need to have in our profession that are both cultural and policy changes. We got to change curriculum, yes, but the same bias that sometimes exists around addiction also exists within our professions, right? I remember when I was training in medicine very early on in medical school, in fact, I was in the emergency room, and we were taking care of patients who were coming in, and I remember somebody saying to me, "Oh, those are the folks who are coming in looking for drugs. It's basically the same folks all the time." And there was a certain way in which they said it, which led me to think, "Oh, well, this is a problem that might be maybe more their fault, than a biological disease." It led me to think of it differently than I would if it was a patient who was coming in again and again because they had trouble with their blood sugar, or a patient who's coming in again and again because they had trouble with their blood pressure, right? And so those signals, which I think are cultural elements, start very early on in our training, in how our attendings and how our senior residents talk, about the patients who come in. So that's part of what I think we have to do. So all of the efforts that are in place right now with the AMA and other organizations are good and they're helpful, but this has to be part of a larger strategy where we get information to people, but we also impact their training, and we have a larger call to action of the profession to change how we think about addiction as well.
Let's see. How about, yes.
Right. Okay.
Thank you.
Whoever has the microphone is next.
Thank you. My question is there anything going to be done about on a state and federal level in regards to, we talk about prevention, but then there's the individuals that end up getting in trouble because crime and addiction comes together. And we have a lot of individuals, and I know because I live here in the Mat-Su Valley is really bad when it comes to home invasions. And then my son was murdered last year, which is the reason why I went to meet with Dan Sullivan and other senators. But there's so much crime that surrounds addiction because of the desperation of the individuals wanting to not be dope sick or whatever. And then they're arrested either for stealing or like the man that killed my son. And then they go to jail, and there's no medical resources or help or even treatment within the facilities to get them the help that they need. We don't have prevention, but what about the prevention for before they get out?
Well, first of all, actually, let me just come in. I'm so sorry about your son. I'll tell you that some of the most tragic experiences I have as I travel around this country are hearing from family members who have lost brothers and sisters and sons and daughters and mothers and fathers related to addiction, whether it's because of an overdose death or because, in your case, because your son was harmed. I think you brought up a really important point, which is that we have treated addiction with a criminal justice approach a lot in our country. We've taken people and put them in jail who actually really needed treatment. And I understand, why that came about, because in some ways we criminalized addiction. In other cases, folks who who were living with substance use disorders may have committed crimes, and we felt, okay, those needed to be punished appropriately. But if our real goal is prevention, like you said, if our goal is to both prevent addiction and prevent the crimes which sometimes can come from that, then it makes sense that we gotta treat early, and we gotta make sure people have information to prevent addiction in the first place, right? And this is why, as you probably know, there are many states in the country which have begun and created drug courts, which are courts essentially that take people who are nonviolent offenders and who direct them toward treatment instead of putting them in jail. And they do that in part because they recognize, again, that the problem is that there are folks who need treatment, not incarceration. And many of those programs have been incredibly successful. I've met many of the judges who have presided over these courts. I've met many people who have actually gone through drug court systems and who are actually living productive, contributing lives, and are grateful that they had an opportunity to do so. But the truth is that doesn't happen everywhere in our country. And that's part of the mindset, the shift that has to happen. That's part of the system shift that has to happen, is we have to recognize that folks with addiction actually need treatment more than anything else. And when I was in Seattle just a few days ago, I was with the Seattle Police Department. I spent an afternoon with them. And the chief and others were telling me that they feel that a lot of the break-ins that happen in the area are usually drug-related, and that they're often driven by folks who are living with addiction, who don't have access to treatment, and who might be looking for money or for other ways to purchase drugs off the street. And to me, that also, and that's a tragedy, right? Because every time something like that happens, somebody's home might be getting broken into. A police officer may be putting himself or herself at risk, trying to investigate that situation. The person who's actually breaking in suffers from a disease of the brain and may not be able to control their reasoning or their judgment, right? So there's a terrible cycle that's happening here. But the key is, I think, that we have to recognize the disease early. We have to have enough treatment available so we can get people into it. And we got to know enough to actually prevent this early on. And that's why, to me, focusing on changing our prescribing practice is so important. It's not going to solve everything. But if we can close the spigot on the supply of misused opioids, we can protect more people from developing full-blown substance use disorders and addiction, which in turn can lead to a whole bunch of terrible consequences for them, and in some cases, is sadly the case for your son, for other people as well. And the truth is, your son didn't deserve that, you don't deserve that, your family didn't deserve that. And that's why we owe it to you and to everyone in our society who has lost a loved one for a reason related to addiction, to do everything we can to make sure we're preventing this, to change culture, to allow more people to come forward and get treatment, and to invest so that we have more treatment facilities available so people can actually get the help they need. Thank you for sharing your story. Appreciate it. Let me find a way to get back up here.
The problem with not having a fire for the fireside chat is the Surgeon General wanders off. But
I do have a tendency to wander off. My staff tells me this all the time. I was, if you'll indulge me, I'll tell you a quick 30 seconds. I was in Liberia dealing with Ebola last year. We had officers from our commission corps who had gone to set up the Monrovia Medical Unit. And my staff usually tries to keep a tight leash on me because they know I have a tendency to wander. So one of the other officers, senior officers, said to my aide, "Why are you always sticking so close? Just give him some breathing room. Let him, move around a bit." So of course I wandered off, and then the president of Liberia, Ellen Sirleaf, drives in and is looking for me, and they can't find me because I've wandered off. So they keep me on a really tight leash now.
Okay. I thought that was part of your physical activity plan.
Wow.
Right
so
here.
we have time for one more question, and I
Right
think the microphone is in somebody's hand.
Right.
Yes. Thank you.
Wow. Thank you.
Thank you for your
Thank
patience.
you. Well, I really want to thank you for coming to our state and actually talking to us about this opioid addiction problem. I'm a vet, and I actually have been taking opioids for a number of years, actually. Actually, I'm not addicted to them, but the fact of the matter, I've been taking them. But what I'm looking at is this, is that I've listened at a lot of the information that has been given to us here today, and Dr. Lee, who is in charge of policy, talked about working across disciplines and pain management and I think detox measures and things of that nature. Now, I'm going to swing this thing into an opposite direction. As a veteran, I've talked to a lot of my cohorts and friends who are in the same conditions as me, who we have a lot of parts that are still being put back, you know? So we have a lot of pain. So what we're looking at is the cannabis portion of this. Now, I've heard you guys talk about this, but you haven't said very much about it. I saw, I think Dr. What's her name? The HHS.
Dr. Wakefield? Is that
Yes,
who you're thinking
Dr.
of?
Wakefield mentioned something, and she showed a graph that had the cannabis on it, but she didn't really mention anything about it. Now, what I understand is that all over the state and all over the states, they're talking about using particular marijuana plants and et cetera, CBCs and all of these things and extracts to help people get away from the narcotics. And no one is actually talking about that portion of it. And basically, it's a big issue here in the state of Alaska, because they're in some other states too, because people are trying to grow it, they want to sell it, they want to do it, you know, use it for medicinal purposes. And I've actually tried some of the oil and some of the topical stuff for my joints and pains, and it works great. However, the fact of the matter is, getting it is an issue. I'm a vet. The VA will not approve this stuff. So what I'm trying to ask, the question I'm asking is, why?
Good question. Thank you. And sir, before you give the mic back, can you tell me your name? Don't worry, I'm not going to send someone after you. Don't worry.
I'm Reginald Bright, sir.
Reginald, and where did you serve, sir? You mentioned your vet.
I served here in Alaska and in Iraq.
Oh, wow. Well, first, I just want to thank you for your service to our
Yes,
country.
sir.
I really appreciate that. And I imagine there are many sacrifices not only you have made for our country, but your family as well. So I thank them all for that. You asked a really good question, and I want to share two things with you about this. So one of the points that you raise is a good one, which is that if we want people to treat pain with non-opioid approaches first, we got to ask ourselves, what do we have in our toolbox, right? And what I'm here to tell you is that there are items in the toolbox, but not nearly enough. Okay, so for example, we know that there are some medications like Tylenol and NSAIDs that can be used to treat pain. We know that physical therapy can be a powerful tool for treating pain. We know that cognitive behavioral therapy can be important and can help as well. We know that there are other techniques that are being used to address pain, like meditation and acupuncture, which have been showing some promising benefit. But we need more, which is one of the reasons why just a few weeks ago, in fact, the Department of Health and Human Services announced that the National Institutes of Health, NIH, which funds a lot of the medical research in our country, is actually focusing in on identifying newer treatments for pain so that we have things that are safe but also effective to treat pain with. Now let me talk specifically about marijuana, since you brought that up. And your question is, why is it so hard to access marijuana to treat pain, whether it's through the VA or through other systems? And for context, you know, many of you here in Alaska are obviously aware of the marijuana issue because Alaska has taken steps from a policy perspective to legalize marijuana. And other states have too. Colorado now has recreational marijuana that's legal in addition to medical marijuana. Seattle, in Washington State and in Oregon, they have similar laws as well. But here's some of the challenge when it comes to actually reimbursing for these things. For something to generally be reimbursed, there has to be a strong base of evidence, scientific evidence that shows that it is both safe and effective, right? So, for example, like some of the blood pressure medicines that some of you may take, or the cholesterol medicines that you may take, have actually been through rigorous clinical trials to understand, number one, do they work? And number two, are they safe? When it comes to marijuana, when researchers and scientists have aggregated and put together all the data that exists on marijuana, and there's a lot of data, like on marijuana, But the question they've asked is this high quality data that we would use that would make the case for approving this as a safe and effective drug or not? The answer has come back that there isn't yet enough high quality evidence that tells us that marijuana can be used safely and effectively to treat medical conditions. Now, this is contrary to some people's experience, right? Because there are people around the country who have spoken up and said, well, look, I've used marijuana and I feel like it's helped me, for a given condition, whether it's pain or for other symptoms. And that's actually one of the reasons why, I believe that we need to continue to invest in, but actually accelerate our research in this area so that we can understand how, if marijuana does indeed have therapeutic effects or not, and then how to actually use it properly. Because right now, if someone were to say, well, I think marijuana is good for back pain, right? The question would be, okay, in what dose, in what frequency, what are the potential side effects, and which patients should it be given to and not given to based on their patient profile? And a lot of that information we don't know because it hasn't been studied to the same extent that other medications have been studied. And then the final question is then why? Why hasn't it been studied? And so number of people have raised, rightfully, the concern that there have been barriers to research for marijuana that don't necessarily exist for other substances, right? Some of this has to do with how marijuana is classified. Some of it has to do with other administrative hoops that people had to jump through in order to research marijuana. There were some researchers who have been sure where to actually get the marijuana to do their research on. And frankly, if you just buy stuff off the street, it's of variable grade and quality, right? So if you're trying to do a rigorous research study, you need to have the same quality, consistent product that you're testing in order to draw any meaningful conclusions of that. So a few steps that the administration has taken. Number one, it's actually significantly increased the quantity available of research-grade marijuana so that people can actually do studies on it. Number two, the government is actually already funding about 60 or so trials and studies on marijuana, looking particularly at benefits and potential harms. And number three, there have been some administrative hoops, including one called the Public Health Service Committee Review, which have actually been removed to make research easier, right? But this is something we should continue to push on, because the truth is that science should drive our policymaking, right? Not someone's opinion about something, not ideology, right? That's how I've always operated in medicine. I say, I don't care where the medicine is coming from or who's making it. What I care about is it going to be safe for my patient? Is it going to help them with a concern that they have? That's what I want as a doctor. That's what I want for my patients. I'm sure that that's what they want as well. And that's why I want to make sure that we are investing in that kind of research so we understand what works and what's safe, and so that we can ultimately get that to patients. But until we have that, it becomes challenging to justify how to actually pay for it if you're an insurance company, in particular if you're the VA. Thank you.
We'll wrap up. Well, thank you, Dr. Murthy, and thank you for coming to Alaska. This is our home. You, I think, have had some vision of why we love it so much, and we just really appreciate your partnership working with us to make Alaska a safer and healthier place.
Well, thank you so much. I just got to say how grateful I am to have had the opportunity to come here to your great state. I'll be honest, I've heard people rave about Alaska for years before I came here, and now I fully understand why. Because you have an incredibly beautiful state, but even more important than the natural beauty is that you have strong, resilient, and beautiful people who just are committed to the state, who want to be a part of addressing challenges like the opioid crisis, and who I believe have the intelligence and the resource and the spirit that can really help take us to a place which is a place of solutions, which is different from where we are now, where a lot of people are worried about how we're going to move forward. So I just want to thank you for the opportunity to be here. I want to thank Senator Sullivan again for inviting me and hosting me here. Thank Dr. Butler for his presence here and for all his leadership on health issues for the state of Alaska. And lastly, I just want to tell you that this is a important moment for us, not just as the state of Alaska, but as a country. This is one of those moments where we're not just talking about the opioid epidemic, but how we respond to this epidemic actually says a lot about who we are as a people and as a country. And my parents came to this country when I was very young. They came because they believed that America was a place where their children, my sister and me, would be able to live healthy and happy lives. They believed that America was a place where we would be judged not by the color of our skin or the fact that we had a funny sounding name, but by our willingness to work hard, by the ideas that we had. And you know what? They were right. And even though our country is not perfect, even though we've had our challenges at times, and we're living through some of those challenges now, our country is a place where people have, over history, come together to solve problems that were bigger than any one person could solve on their own. And that's actually what we have to do right now. As much as individual effort and individualism is part of the American fabric, collective action is also an important part of the American fabric. We didn't win the Civil War, with one person alone. We did that together. We didn't expand the right to vote for women with one person alone. We did that because millions of people stood up and demanded something that we knew to be fair, both in law and in spirit. And this is one of those moments where what we do together to address the opioid crisis will really reflect on the spirit of who we are as a country. And if we can come together and address this crisis effectively, it will not only help save people's lives and prevent people from living lives of suffering, but it will also give people in our country confidence that we can in fact take on big problems and that we can in fact solve them together. So that's why this issue is so important, because it's about opioids, but it's about a lot more than opioids as well. And that's why I'm so grateful that so many people in the state of Alaska are stepping up and coming forward and want to be a part of the solution. And it's with that spirit and with your energy that I believe will ultimately overcome this crisis. Thank you so much, everyone.
Now hold on a minute, not so fast. I can't thank the Surgeon General enough, and Dr. Butler. You got some great questions. You got a good one from Reginald Bright, who to many of us is known as Pastor Bright. And I also just wanted to mention not just inspiring words, but inspiring life story. I've said I'm not reading the bios because we're trying to get to the business, but when you look at the Admiral Murthy's bio, Harvard undergrad, Yale medical degree, an MBA from Yale, Harvard medical professor, Harvard Medical School professor, Vice Admiral of the U.S. Health Services, now Surgeon General, all at the tender age of 39 years old. So I just wanted to embarrass you in front of Alaskans by just letting you know we really appreciate you coming here, and we're going to make sure that you continue to stay with us and help us, and Senator Murkowski and I will continue to do that with you back in Washington. So how about one more round of applause for the Surgeon General? Okay, wow. Maybe we should just end it with that conclusion. That was amazing. Well, listen, we have 2 final sessions, and one is going to be a breakout session, which we're running a little bit behind on, but I think it's going to be very important. And then the final session will be back here, again, moderated by Dr. Butler, who you see does such a great job. And that's going to be about the different pathways to recovery, which I think is going to be really important discussion. So what we're going to do now, and we need to expedite it if that's okay. Over in the Makatans building, there are 8 classrooms. And here's how it's going to work. Each breakout session, if you look at your agenda, they have the different breakout sessions. We'll have a note taker and a subject matter leader. I want to emphasize this because all of our note takers are people in long-term recovery. So think about that. So their courage is going to be on display in your breakout session, and they're dedicated, as the Surgeon General mentioned, to helping others. So please thank them. Thank the subject matter leaders. In the breakout sessions, there's going to be 2 tracks, a blue and red track. If you look at your agenda, you can go to any room you want. The blue track is generally focused on resources here in Alaska, and it has more details on the topics. We have peers in recovery, community coalitions, and then the red signs, the policy breakout rooms there, are more about policy, federal government, and policy solutions such as integrated healthcare, law enforcement and the court system, veterans, treatment, rural Alaska. So again, we have 8 breakout rooms. Only about 40 minutes to do it. We're going to try and take some of the ideas from the breakout rooms, get them back so Senator Murkowski and I can take these back to Washington. You're going to have the members of the Job Corps here in Palmer help escort you. So again, thank these young Alaskan kids. They're great, the ones in their uniforms. There's coffee and snacks to grab on your way over to the Makatans building. You'll get the ring. 40 minutes and we're back here. Thank you very much.